I've got John with me today to talk a little bit about some of our different treatment options, in particular looking at kind of some of our oral medications that really is kind of exciting time to be in diabetes now because going way back, a lot of our medicines, while they may have controlled diabetes, just had so many side effects and only worked on diabetes. And so really kind of looking at the difference between taking some of our oral medicines and when and how do we transition to insulin. What's your favorite go-to medicine when somebody comes in to kind of start off with, and why do you like that one?
Well, initially, when the patient comes in, they're first diagnosed with diabetes, a good go-to medicine is metformin. It's a good oral, low cost-effective medication that has good results. We like to usually start them off on that.
It's so old.
It's very old. It's been around a long time. Few side effects, but it works well.
I think if somebody patented metformin today, boy, they would just be like instant billionaires because medicines don't get to be old medicines by being bad.
Right.
For sure. And even there's some of the new research that's coming out with metformin going down to the cellular level, that there may be some benefits, even down to benefits outside of just diabetes, that it may slow the aging process of cells and things along those lines. And it's just a fantastic medicine that we use. The side effects. What side effects do you normally?
The biggest complaints you get is diarrhea.
Yeah.
And a lot of times the patient, if they'll stick with it, they can kind of get through that hump initially. But some patients, they have extreme diarrhea with it, and it don't matter if they take it with food or whatever.
Yeah.
They give up on it, and the diarrhea, they don't want to deal with that. So
yeah, sometimes I'll see some nausea with it. It just really can sometimes upset the stomach. But yes,
But they've come out with some extended releases that kind of break it down over time during the day, and that kind of helps with the diarrhea, so they don't get one big punch at one time. So they're making changes to try to make the metformin a little more tolerable.
And a lot of times too, as we move into some of the other classes of medicine, some of the other classes of medicine a lot of times will combine their medicine with metformin, and so you're actually getting this really nice extended release, which helps people tolerate metformin, which is really another reason that I like to start with metformin, is because it then gives a segue into, if you have to add another medicine, a lot of these have combination medicines that go along with it. And I think that's really one of those things that's really helpful to be able to start with metformin, because it's very effective and it's cheap.
It's cheap.
And it's been around forever, so all the ins and the outs of the medicine. And like I say, just a couple side effects there that sometimes we have to deal with.
Yeah.
What's one of your other favorite classes of medicines that you like to go to?
Of course, some of the other medicines that are good, or some of the sulfurias have been around a long time, but you kind of have to be careful with those because they can really bottom out the blood sugar. But they're good, cheap, cost-effective. A lot of the GLP-1s, the newer medications now, are good. They're in pill form, some of them.
Yeah.
For some of those that are hard to control. But they've come out with so many now. There's just a big array of.
The other class, the SGLT2s is another class. When they first came out, I was against them a little bit, just because I felt like the mechanism of action I wasn't a big fan of. But what we've seen is just over the course of time, not only do they treat diabetes, but also even with chronic kidney disease and congestive heart failure.
Right.
Some of the studies that came out, we're used to medicines when they come out later, we go, oh no, there was this terrible side effect. Well, with this one, it was really interesting because like 5 or 6 years later, they started noticing that people who had kidney disease, the kidney disease wasn't progressing as fast. For people with congestive heart failure,
right.
A lot of times they were treated with that. And I think there's even a couple indications now for congestive heart failure for those.
Yeah, because it actually works to block the reabsorption of sugar in the kidneys. So that's where you get a lot of that benefit to the kidneys. That helps take some of the strain off of that.
Yeah, and a lot of times, even I hate to say, they're not designed to be diuretics, but you almost get a diuretic effect with it, because it's
pulling that
pulling
sugar out.
that sugar out in that water. And the other side effect of that a lot of people tend to like is they lose a little bit of weight.
A little bit of weight, yeah, that's right.
With it. But that class of medicines too isn't without some of its faults. I have had a couple of people that have gotten urinary tract infections and things like that more frequently.
That's been the biggest complaint I've heard is urinary tract infections in the women taking it.
Yeah. And then, we mentioned that the GLP-1s, most of those are injectable, and I will just kind of dedicate a whole series to that. But
Right.
there are a few of those that are oral, and what are your thoughts on those?
Those are good. So semaglutide is the same active ingredient as in the injectables, and it's a step medication as well. A lot of times,
What do you mean when you say a step medication?
we like to start them out on, say, like a 3 milligram dose, which is not really a dose that would get their A1C down or control their sugars, but it would get their body used to having that medication, because some of the side effects are nausea and vomiting with those. So we kind of start at a step method and start to kind of get their body used to it, and then you kind of gradually increase every 4 weeks, excuse me. You go from 3 milligrams to 7, and if they're tolerating it well, you can go up to 14 milligrams. Just depending on how their A1C does and how well they tolerate the medication.
With that nausea, do people get a little bit of weight loss with that as well?
They also get weight loss with it. It has the same kind of, I don't know if it's as good as the injectables, but it's the same medication. So they do see some weight loss with it. And it's just very important that they, it's kind of regimen where you have to really take that first thing in the morning on an empty stomach, before you eat or drink anything, or it kind of it don't work the way it should. So you got to be, take this medication at a certain time and as it's prescribed, or you don't get the benefits from it.
So, and we'll talk a little bit for folks as well. When we begin to make this transition between taking oral medicines to shots, right? That's always a big jump for people, because when they move from taking a pill to taking a shot, I think that's really tough, just mentally and psychologically for folks. How do you help some of your patients walk through when it's time for that transition?
Well, a lot of times, if with my patients, if they're uncontrolled and we see that they're not getting their A1C down to where we like it to be, of course, with most diabetics, you want an A1C under 7. But if you start seeing them get 9 or above and you're not getting any better with the oral, then it's time to start looking at adding an insulin to that regimen. And a lot of them, it is a big jump, and it does scare a lot of patients. But you just gotta, encourage them.
We keep talking about A1C and how to control our A1C. And I think it's important as well to be able to say exactly what our A1C is.
Right.
And so when the body is making red blood cells and making hemoglobin, based off of what your sugar is at the time that molecule of hemoglobin is made, right, a certain percentage of that will have a sugar attached to it. And because red blood cells last about 90 days, then we're able to take those red blood cells and look at what percentage of hemoglobin has sugar attached to it. And once we're able to determine that from just a simple finger stick and just a 5-minute blood test, that gives us an average of 90 days as to what that blood sugar's been running. So it doesn't really tell me what the blood sugar was this morning or last night or any particular time, but it just gives me on average about what the blood sugar's been running. And study after study has shown this is a great way of looking at a diabetic's overall control for 90 days, because that's how long those last. But and I think using the A1C is always a really important thing. We also like to use fasting blood sugars in there as well, because that gives us some of the same information, but it also gives us just a more detailed information sometimes.
Yep.
And I think that's the other thing I think a lot of times that I see is when people transition to insulin, we have to start checking their blood sugars more often. And that's another kind of mental hurdle for people to jump over. And like I say, you just have to encourage them to be consistent with it and understand that controlling some of the side effects of diabetes is directly related to how well we can control their A1C.
Right. And also with those insulins, sometimes people have to take mealtime insulin. They have to take insulin at night or in the morning or twice a day. And a lot of them have concerns about, they worry about their sugar getting too low at night. And
that's a great point.
What happens if something happened in their sleep or different things of that nature. So there's a lot of concerns that go along with it, but you just kind of have to explain to them and teach them the proper way to take it. And they need to eat properly and have mealtime, bedtime snacks maybe to get them through that period while they're sleeping. The insulin's working, but it could be getting the sugar too low. So, it's just something they have to tweak and kind of keep up with on a daily basis. And
well, I can even remember training back in, and I don't feel like it's been that long, but it's been 20 years now. But when we have to use 70-30 insulin, or 75-25, and all these different old forms of insulin that we don't use much anymore, but man, everybody, right, would just bottom out. And some of our newer insulins, and a lot of them are generic now, that last for 24 hours.
Right.
Yeah, that risk of low blood sugar in the middle of the night just goes way down.
Way low. Yep. And now they have them, where the old days of having to, have a big vial and draw up the insulins, and people worry about getting that wrong. But now technology's come so far. Now they have them in a small pen, and they just kind of dial the number up, and they're able to give themselves, this injection. And
that needle is so small, right? I mean, it's actually a lot of times when you're moving to that insulin, taking the insulin is easier than checking your blood sugar.
Right, exactly. So yeah, they're so everybody's been pleased with that, and that's made a big difference, I think, in the insulin game.
And I like to, now again, it's just an exciting time because now with the continuous glucose monitors in conjunction with the insulin, that also, for me has made a big difference in being able to more accurately dose insulin and titrate the insulin quicker. Because one of the great things that we can do here is, if people have one of the glucose monitors, they can automatically upload that to the computer, and then when we're looking at that in between, if it's going off the rails, it's alerting it.
We can see it, right?
Yeah.
Yep, and notify them, say, hey, are we taking our insulin like we need to, or we're eating something that we shouldn't be. So yeah, we're able to keep our finger on it as well and help them through that process.
Yeah, I can think of a couple of patients just off the top of my head that when their sugar spiked, we were able to see that here and call them and be sure they find out they had ran out of their insulin and get that to them before they ended up in the emergency room or being admitted.
Yep.
The same thing with low blood sugars. If we start seeing it trend a little bit low, I think that's another one of the hard things just with patients, because once the blood sugars have been running low for a long time, they quit feeling it.
Right.
And so, with that program, that's been really helpful too, to be able to see people as they're starting to have some of those dips that we can quickly adjust that insulin.
Right.
And keep them from continually having these low these low blood sugars, and then they don't feel it,
right.
Which is really dangerous as well.
Yep. Yeah, it's definitely it's a terrible disease, but it's the way things are now. It's easily controlled with diet and exercise and the right medication regimen. They can live a happy, prosperous life and get along with it.
Yes.
Pretty well. A lot better than they probably did 20, 30 years ago. So.
It really is an exciting time to be able to treat diabetes compared to even just 10 years ago.
And there's just so many tools in the toolbox now.
Absolutely. Well, it's always good to get to talk shop a little bit. Appreciate you coming up and talking. And I'm going to let you get back to work. But it's always good to be able to look at just, especially with diabetes, right? This transition between oral and insulin, I think, is so important. But it's also important that we're able to maximize things outside of medications as well. And so I think that's been one of the things that I've appreciated about your approach just in the clinic, is to be able to try to hit all of those aspects and keep people from having to move all the way to insulin, but knowing that we can if we need to.
Yep.
So,
all right. Well, thank you very much.